Thanks again for joining us on another edition of Laser Chat, where aesthetic experts get together to talk about their individual approaches and techniques on a variety of cases with each other. Not surprisingly, most of the time they agree, but not always. Today's experts, Dr. Kian Karimi and Joel Cohen, are comparing cases with each other.
So Kian, this patient came in early December. She complained of really a lot of visible sun damage. She spent a lot of time outdoors, and by the time of the holidays, she really wanted to look refreshed and improved in terms of pigmentation and overall photo damage. So, thoughts on approaching this patient?
So she came early December, wanted to look good for holidays?
Yes.
Okay, so that's a tight window. So for this type of patient, I see the dyschromia as kind of the #1 issue, but also the rhytids around her mouth as probably equally, if not, greater issue. It really depends on what she perceives as looking refreshed. I would query her on which one kind of bothers her the most, but I would approach this patient with a combination approach. And BBL 100% would be part of anything that I would do for her. I would probably do, she looks like a type 2 to 3 fit skin Patrick scale to me. So I would probably start with a 515, maybe test like 8 or 9 joules and see what that does with the rectangle. Probably if she has any reds there, which looks like she might, I might run it over another pass with a 560. Definitely spot treat as well. I like to crank it up with the 7mm spot and do like 15 joules on the little, on the brown spots themselves. I would also 100% do a halo on her. She would, with 3 weeks, that's kind of the perfect sweet spot for a halo healing. So I would probably do, for the non-ablative, anywhere from 400 to 500 microns, 25 to 30%. And then for the ablative, since I had a few weeks, I'd do probably 40 to 50 microns. And this is the patient I would actually talk about doing the laser first and then having her maybe come 1 or 2 weeks before the holidays to do some intradermal fillers for the rhytids, because I would love to fully ablatively resurface her, but the time frame I don't think would work for the holidays.
So that was my approach. So I did BBL, and then I followed that up by halo, same session. And you can see here, I did 515 filter alone. I used the rectangle throughout the face, and then identifiably went using the small circle or the large circle, using the 515 as well. But I made the pulse duration 10, and then I was basically at about 10 or 11, just hitting the individual spots, making sure I saw the cayenne pepper. And then I went over the area with halo. My density was only 25%. So really, she had a nice improvement. And this is not something I tell patients that to expect to see much in terms of fine lines and etched lines from a long-term basis, because I do a lot of profractional and a lot of full field resurfacing, and I want to make sure that we pick the right tool for the job. Early on when people started to get halo, I think people in some cases misrepresented what halo was going to do, and where I saw patients who came to my practice and said, I've had halo before and it didn't work for these lines. And I said, it was never meant to work for those lines. You really need to do a combination of fractional and full field resurfacing, and halo is a great treatment for sun damage. And if you think about the name, it's really that light reflection and the glow, and the fact that people are going to have a better luminosity to the skin. And I think you can see that very clearly. So her pigmentation is significantly better, and overall light reflection is better. And you can really just appreciate that she has a much better appearance in terms of the luminosity to the skin.
Beautiful result. I don't know if I missed it. Did you mention how deep you went on the ablative for the halo?
So I was at 30.
30 microns, wow. So why don't we move on to my patient here. So this patient came to me, she's 60 years old, and she came primarily because she thought she was looking tired, but she was also bothered by the dyschromias on her face. I don't think this image shows it, but she has kind of a large brown spot on the right side of her cheek, which we don't see here, unfortunately, and I don't think we see in the before and afters. But she basically said that in addition to eyelid surgery, which we discussed and we were going to proceed with, she was wondering what kind of lasers I could do for her while she was asleep. So what would you do to address her dyschromias?
I think seeing this patient, and if she was willing to do sort of a series of treatments, I would do BBL plus Moxie, the thulium 1927. But as you mentioned, she was going to be asleep and she would want one treatment and see noticeable improvement. I think I would handle this patient very similar to the previous patient with BBL plus Halo, and she'll see very documented improvement with one treatment session in the pigmentation. But I think it's really dependent on using the right settings. I think she does have a little bit of color in the cheeks that she doesn't have in the high forehead. So I think we have to be very careful. In terms of the 515, I would do the square to the density of the cheeks at about 8 joules, 25 milliseconds, and then take the square off and put the small circular piece on, and then I would go to the individual spots specifically at about 9:15, and then hit those individual spots, and then I'd wait to make sure I see the desired endpoint, which sometimes takes a good 4 or 5 minutes. And then my approach with the Halo would be pretty low. I wouldn't go over a 20% setting. I would really be probably 300 at 20%, and maybe close to 20 at 20% on the ablative. And I think she should have a nice outcome with that.
Yeah. So if you want to go to the next slide, that's actually very, very close to what I did. So in addition to the upper and lower blepharoplasty, I treated her with the 515 with the square. I only treated the cheeks at 8 joules, 25 millisecond pulse width, and then I actually put on the 7 millimeter and did both 9 and 10 because I didn't see as much response I wanted from the 9. And the 10 I saved for the big one that you don't actually see on this photo, and I just did a one flash of that. And then after that, actually, I did a 350 micron non-ablative 1470 25% Halo, and I did 30 microns on the ablative. Now, I will say that for my Asian patients, which I pretty much stratify as a type 5 immediately, I do pre-treat them with compound cream 1 to 2 weeks before doing a Halo treatment. And then after the crusting falls off, which would have been probably 5 to 6 days for her, I have them do it for another 1 to 2 weeks afterwards to minimize the incidence of post-inflammatory hyperpigmentation, which fortunately did not occur. So all in all, she was really pleased with her results, and that's exactly what we did. I'm curious to learn more about Moxie and would love to hear your use of Moxie. I don't have Moxie yet. And so I'm, a little bit more limited in how I approach these types of patients. But for the one time being asleep, the BBL Halo was perfect, and the settings were nearly identical for what you predicted.
So, this patient is a lovely lady who was a single mom for many, many years, special ed teacher, and she came in and she really wanted to do a treatment that would make a noticeable difference, and just didn't have the money to do it. So I said, hang on. I said, I'm doing a Sciton course at my office, and let's just make it work for you. And there were a lot of other docs there, but I did the treatment, and we did one treatment, even though I prepared her that very likely around the mouth, we may be considering doing 2 full field erbium resurfacing. So, this is a patient that had pretty significant downtime. Her time to healing with the full field erbium around the mouth and eyes was about 2 weeks. So if we look at the next picture, the before and after, you can see that I used very high settings. I would argue that she has some hypopigmentation to begin with. That's part of that sort of solar elastosis and sun damage changes. And she had had some peels before, but I couldn't get a great sense of if she had phenol or if she had TCA or something else. But I think we really hit a home run here in terms of what she was looking for. And you can see a little bit of pigment alteration perhaps, but I was at some points, I was at 650 to 750 microns by the time you tally everything up, chasing out individual lines. So this patient had full field erbium around the mouth. She had profractional throughout the face, including some areas around the mouth, which sometimes I'll use for hemostasis, where I'll put on a coag of 3, just lightly go over the area. And I think by poking the little profractional hose with a coag of 3, you get a little coagulation of the bleeding that's pretty significant at this point. And then plus poking the little holes, I think shuts down some of those little vessels and helps contribute to the swelling, the pinching off of some of that bleeding. So, you know, I think that this is one of those treatments where I don't think that there's a great alternative to the Sciton full field 2940 resurfacing. I think there's a few people in the world that are experts at using full field CO2. I certainly used it in my fellowship, but I don't feel like I have that control. You know, people look, and I talked to Susie Kilmer, and she says, I can see that skin kind of tighten. But in my mind, you know, I approach this with full field and no coag. I want to see that pinpoint bleeding. I want to know my endpoints, and I actually do my blocks and my full regional block around the mouth with plain lidocaine, 2% plain lidocaine. So I had a new nurse today that was circulating while one of my main nurses was assisting, and I was doing a procedure very similar to this. And the other new nurse had worked for one of my close friends in another city and happened to move to Denver not that long ago. And, you know, we had this discussion about the to epi or not to epi. I really don't epi in my regional blocks when I'm using full field, because I think it's so important to see that, you know, your endpoints.
That's an amazing, amazing result. Wow, congratulations to both of you. So you mentioned the profractional with the coag 3. Do you do that in the beginning before you do the full field ablative, or midway through, or when do you do that?
I do it at the end. I really follow those lines around the mouth and really make sure that I feel like I'm truly effacing those lines. Sure, I could have been probably a little bit heavier in the chin, but if you look at this, I mean, that poterange orange peel texture that she had is significantly improved at this point.
Oh.
And yeah, you can go back to some of these areas, but you know, I think that the coag 3, even though it's slower, really helps with some of the hemostasis.
Right. So you did profractional on her upper third and mid-face?
And I did.
How did you go to do that?
I did full field around the eyes, and you can see, you know, some of the improvement. I think, you know, sometimes on these front photos, the eyes are not as etched, so it's a little bit harder to see than you would see on sort of the lateral view, where you can see a little bit more of that creping skin. And I think she has pretty significant improvement around the eyes as well. But, you know, the biggest issue when you look at her pre-picture is this perioral area. And if you think of one treatment, you know, I don't think that there's another treatment out there with the safety and the efficacy of this. You know, some people may actually feel that doing a phenol and TCA peel would be an appropriate treatment, but I think there's very few people out there. There's the Peter Roulans that can actually get great results and do it consistently and understand how to use phenol and the cardiac monitoring. And with this, with the full field 2940 from Sciton, and really just seeing the improvement that you can get from the recognition of that endpoint of pinpoint bleeding.
Very nice. All right, so this patient is a 52-year-old physician. She's also the host of a television show and needs to be on camera in 2 weeks. Came to me primarily for refreshing her lower face and neck, which you really, you know, from the front view can't really see, but just wanted a more youthful lower face and neck. So we did like a little mini neck lift for her, upper eyelid blepharoplasty. But while I was looking at her, I was like, your skin, we got to do something for your skin. And so she said, well, you know, what do you recommend? Something that's, I'm going to be ready to go in 2 weeks. So how would you approach her skin?
You know, she's obviously a very pretty woman. And, you know, from a perspective of a television host and a specific time frame like that, it's always frustrating because patients just never give you enough time. However, I think the better approach is to do halo here. So I think, she can probably have a really nice result with the halo. I'm surprised. I think it's really the 1470, and I've talked to Jason Posner about this, but I think with halo and the 1470 component with the non-ablative getting some coagulation, that we can see improvement in people who have some central facial rosacea. So I think she does have some actinic damage. You can see some of that actinic bronzing. You can even see some poikiloderma of Sciton on her neck, where it spares the area underneath her chin, and then you can see the sun damage here. And I think a halo face, neck, and I can't see her deco, but usually the patients that have this type of pattern on the neck has the same pattern in the deco, and I see no reason why she wouldn't be happy with the recovery time and the improvement of photo damage, pigment, smoothness, luminosity, as well as some of the redness I see here with halo.
And settings?
For her and the time frame she's at, I would probably be looking at about 25-30%, maybe 450 microns with the 1470. And I'm not sure I would go over 40 microns given her time frame, because sometimes that coffee grounding that you get from the 2940 part of the halo can really last, sometimes a little bit longer. And I don't think we want to get into that point where it's above a week and she's starting to stress. So I think I would sort of err at about 40%, or 40 microns, 25%.
All right. Well, the big reveal. I need to be paired up next time with somebody less smart, because you're nailing all these settings and you're just making this seem really, really easy. So this is 2 weeks post surgery. So upper blephs, micro neck lift, which is basically like a lower face and neck lift, and then BBL and halo. So so for the BBL, I did both a 515 and 560 filter. I've kind of learned, again, from all the other Sciton KOLs, the different types of approaches to this, but I really like the 515 rectangle to kind of go over everything at 9 or 10 joules. And then for someone with rosacea, I like to put on the 560 square and then go 12 to 13 joules just over the rosacea areas. Then I'll put my 515 back on, and then with the circle, whether the 7 or the 11 millimeter circle adapter, I really like to blast those at like 15 joules, 10 pulse width, to really zap those. For her halo, I did end up for the 1470 non-ablative, I went 450 microns, 25%, and then for the ablative, I did 40 microns. So really, really pleased with her outcome.
The pigmentation and overall photo damage and the poikiloderma Sciton on the neck looks markedly improved. So what were your settings on the neck?
So on the neck, I always kind of dial it down. So there was a lot of brown there. So I did a 515, 8 joules. And then for the halo component, I think my ablative was like 20 microns. And I usually dial down the non-ablative to about 350 and 15% for necks. So
this is an Asian patient who has rolling acne scars. She's done a number of other treatments. And, I think by the time that you and I see many of these patients for acne scars, certainly majority of them have approached things with microneedling, or they've done some non-ablative lasers. And, you look at a patient and you get a sense of what their downtime sort of capacity is, if they have anything major on their social radar where they want things to look better, and what their level of frustration is when they've tried these other things before and they just haven't seen the type of improvement they want. So, we have at our armamentarium with the Sciton Jewel platform and Jewel X platform, a lot of different things that you can do. And, and we also have in our armamentarium other things that we can do, from a standpoint of injectables or subcision and all those types of things. In this case, what would you think that would be sort of the way to handle this in somebody who's kind of like, yeah, I've seen some of you medical people along the way, and I want to get a good result. I want these acne scars to look improved.
So this is the exact time where I pull out my profractional. Profractional, in my experience, has been like the go-to laser, and I've been able to use it on any skin type, even any and all skin types, just dialing the different settings. But I would kind of set her up for a series of, depending on her expectations, I would say at least 5, but possibly 7 profractional treatments. If she's Asian, I might space her out 6 to 8 weeks apart, and I think that is like really the way to go.
So this is exactly what I did. I treated her with profractional, and you can see this is 2 treatments, and she has a noticeable improvement. You can see that these seem to be more shallow, and they didn't go away, but they just look better. In terms of overall, what else we could do at this point, sometimes with the profractional, I'll poke really at the area of the acne scars, and then I'll use a little of the single shot erbium around the perimeter, just to sort of bring down the shoulder of these areas. And then, at the end of that, sometimes I'll actually use a little bit of subcision in the area just to free things up with an 18 gauge no core needle.
So this last case, very lovely, dear patient of mine who was turning 60 years old and just felt like she looked tired, and her primary concern were the rhytids around her eyes, really on her lower lids, and also her perioral rhytids. And so she was just open to any laser, really unlimited downtime, and wanted to know what I could do for her. So how would you approach a patient like this?
So I would do full field erbium resurfacing around the mouth, around the eyes, and in the glabella. And I'd probably do some, for that etching you can see in her forehead as well. And then I would follow that same session with profractional. So I would give her, regional blocks, topical anesthetic, and maybe a Vicodin an hour before. If she wants to take, ibuprofen, 600 milligrams of food an hour before, I would have the Pronox on standby, but I think we can really get this patient comfortable with the regional blocks. I just want to remind people to use intraocular stainless steel shields, so proparacaine drops, and then a lot of lubricant below and above the shields, pop them in, and then start with the resurfacing. I tend to do the mouth area first, just because I think the anesthesia washes away more quickly because it doesn't have epi. And my approach on the upper lip would really be, I would do 100 microns, 100 microns, 100 microns, 100 microns, and then we'd start to see a little bit of pinpoint bleeding, it looks like, and then I would go to a smaller spot size and I would paint out those little lines, and then I would, done with the upper lip, I would feather things out, basically 70 microns, 50 microns, and sort of blend things a little bit. And then on the chin, I would be at 100 microns and maybe about 70, and then 50, and sort of blend things down just to make sure I can see some improvement in that poterange texture to the chin. Then I would, as I put gauze around the mouth, I would go to the eyes, and then I would, on the lower lid area, I would do 80 microns, 60 coag, and I would do that laterally as well as, below the lateral brow. And then I would bring it down to about 60 microns and about 40 coag. And then I'd go the same areas, and then I'd sort of sawtooth around the edges so that we don't see a demarcation at the infraorbital hollow, and taper my settings a little bit. And then in the glabella, I would not use any coag, but I would do about 100 microns and then about 60 microns. And then I would do profractional over the entire face and cover everything that I covered before. I'd probably be at about, 275, 300 microns, 22% for most areas. I might actually go back to do sort of the secondary smile line areas with a little bit more density, maybe go up to 33%. On the nose, if she had more of a sebaceous nose, I might even do 33 or 44%, but I just don't think she needs it. But the nose can be very forgiving, and you can see some improvement in some of the phymatous changes to the nose. But I think she'd have very noticeable improvement around the mouth and around the eyes on those settings. for her, you can see that little bit of tendency central facial to see erythema. And I would caution her that she would be one of these patients that typically I want to make sure she realizes that she's going to be red and have post-inflammatory erythema in the heavy erbium areas for maybe 8 weeks or 10 weeks. And that's something that's tough to treat. We follow these people carefully. We want to make sure they're great about sun protection, using zinc, reapplying. But if she has any element and any hint of post-inflammatory pigmentation, aside from the erythema, I wouldn't hesitate to jump in with a topical steroid mid-potency like triamcinolone, or if it was bad, even some fluocinolone Lidex. I would consider doing some hydroquinone if, for a short period of time, and then I would give her short contact Cispra if any indication of that.
Awesome. So this is 6 weeks after her result, and I just ended up using the full ablative erbium YAG resurfacing as a single modality. Looking at her, I do think that she still has some erythema here at 6 weeks, especially in the perioral and periocular region. I did treat all the areas that you described. I did not use profractional. Now you're a braver man than me. I put these patients under sedation in our surgery center. And I kind of I don't do everybody like that. I do some people under local, but for a lot of my patients, they're just the thought of having a full field laser resurfacing. We do a little propofol and do it under sedation. So that really helps make things a little bit easier for both of us, actually. So for her eyes, I learned from Jason Posner, the 80 ablate, 50 coag, and actually I did that. This is about 5 or 6 years old now. I've kind of modified my settings around the eyes to do a little bit of a less aggressive setting on the second time, because I have had some post erythema that's even lasted like 2 to 3 months for some patients when I have been a little bit more aggressive with the full field resurfacing. I remember for one patient, I ended up calling, it was like 5 or 6 years ago, I called Jay Burns. I'm like, hey Jay, there's erythema, it's like 3 months. He's like, tell him it's still healing. 3 months later, that patient was fine. It wasn't this one, but it was another patient. So I did 80-50, 2 passes around the eyes. And one of the things I've been most impressed about with the full ablative resurfacing, and the same protocols I followed that you just mentioned, the Paracan in the eye, lots of lube, stainless steel eye shields, very, very important. But it almost looks like she had a blepharoplasty, and the amount of tightening that you get with the full field resurfacing. So when I get patients, type 1, type 2 with this type of very crepey thin skin around the eyes, I'm very often talking to them about full field resurfacing rather than jumping to surgery, especially if they're younger. Now she's 60 years old, and a few years later we ended up doing her facelift and eyelids and everything else. But for just a single modality, the power of the full ablative resurfacing around the eyes is just awesome. And very often, I don't present any cases here, very often when patients come with concerns about rhytids around their eyes, I'll do BBL halo everywhere else, and then I'll just do full resurfacing around their eyes in the same setting. And the eyes tend to heal really fast, especially when you don't go down beyond the lid cheek junction or get too aggressive in the brow region. So I was really pleased. And then around her mouth, this is one area where I think I could have gone a little bit more aggressive. At the time, I was just kind of going over the whole area without following the etched lines. I was doing 100 microns on the ablate without any coag, but I think I only went like 500 microns, and by that time, it looked pretty well treated. And so I do still see some rhytids around her mouth, and I also know that I didn't go as aggressive because she came back still wanting further improvement of the rhytids around her mouth. So, and just like you mentioned, I tapered the full ablative everywhere else. I think I ended up going like 100 microns for some of the areas that don't really have rhytids, but just so that everything was even. And then I ended up going 300 microns. I did 3 passes for her glabella.
Thanks for watching another episode of Laser Chat. Here at Sciton, we are proud to partner with leading practitioners in medical aesthetics who are willing to share their clinical expertise so that you too can achieve stunning before and after transformations in your own practice. Make sure that you give us a thumbs up and subscribe to our channel to make sure that you don't miss any other episodes. And if you want some more technique tips or treatments or before and afters, please like us on Instagram